Over the next 15-20 minutes or so, I'm just going to present three cases of HNF1 alpha MODY, and I'd like to just draw out the clinical features that are associated with this subtype of MODY, and also draw out the management of this subtype of diabetes, and hopefully help you try and pick out these patients in your own clinical practice. And we would like to try and make this section of the afternoon as interactive as possible, so by all means feel free to interrupt me at any point or comment as we go along. So the first case is a female patient who was diagnosed with type 1 diabetes at the age of 20. This is about a decade ago, and she was found to have a high glucose of 27.7 millimoles per litre, and this was found incidentally when she presented to the doctors with another unrelated medical problem. And at the time she had marked glycosuria and also ketonuria, and when she was talking to the general practitioner she also admitted to some other osmotic symptoms, so polyuria, polydipsia, lethargy, and she'd also had a few episodes of recurrent thrush in the past. She'd not had any weight loss associated with these symptoms, and she was felt to have type 1 diabetes in view of those symptoms, the fact that she was young, she was lean, her ketonuria, and she was started on a basal bolus insulin regime from diagnosis. So as with patients with type 1 diabetes of this sort of age, she was followed up in the specialty clinic at the hospital, and again, like a lot of patients who've got young onset diabetes, she was someone who frequently did not come to clinic, and over the next few years her glycemic control was moderate to poor, ranging from an HbA1c of 7.6 at best up to over 9%. And this is a patient who, because of this relatively poor glycemic control, her insulin doses were titrated up over that time to try and improve her glycemic control, and she ended up on actually a relatively large dose of insulin, about 1 unit of insulin per kilo per day. And the other thing that she found very difficult to deal with, apart from having a diagnosis of diabetes, was that as her insulin doses had been titrated up, her weight had increased markedly from a normal baseline at 60 kilos by almost 20 kilos, and this gave her a BMI that ended up in the obese range. Now, she was carrying along like this, and now some 6 years after diagnosis, she mentioned that her younger brother, who was then aged 25, had been recently diagnosed with type 2 diabetes. And in view of this family history, she was referred to the MODY clinic that was in Oxford, that's run by Catherine Owen, who you heard speak earlier. And as part of her workup in that clinic, one of the things that we do is take a detailed family history of diabetes in family members. So the lady in question is highlighted by the blue arrow that you can see. So to reiterate, she's got a label of type 1 diabetes, diagnosed at the age of 20, now on 80 units of insulin a day, obese with relatively poor glycemic control. And you can see that she has 2 siblings, including a brother who he's been diagnosed with a label of type 2 diabetes, age of 25. He's on metformin, which, as you know, is a first-line therapy for patients with type 2 diabetes. He's got relatively poor glycemic control of 8.5%. So his GP, he was under primary care at this point, had added in a sulfonylurea, and it was noted that he had quite marked hypoglycemic episodes with that medication, and so it was stopped. Looking back through her family history, her mother also has diabetes, and this was picked up when she was pregnant with her eldest daughter at the age of 24, and her blood glucose remained high after pregnancy. This was assumed to be type 2 diabetes, so she had insulin during her pregnancies, but was otherwise managed on metformin and glycoside and actually maintained very good glycemic control some 20 years down the line. So you can actually see from that family history, which up until this point no one had really taken, that she has a 2-generation history of young adult onset diabetes, and so this in itself should make you think about a diagnosis of MODY. So if you remember from what we talked about earlier today, patients who are presenting with non-insulin dependent diabetes, typically under the age of 25, which all 3 of these members were, with a family history of diabetes, and at least 2 of these cases have got non-insulin dependent diabetes. So in the case of our patient, she's obviously been on insulin from diagnosis. So one way of looking to see whether she has any evidence of insulin independence is to measure a C-peptide level, and that's something that we briefly mentioned earlier, but to remind you, this is a protein that is produced at the same time as when insulin is metabolised in your own beta cells. So it's a marker of your own insulin secretion, and we measure that rather than insulin itself, because patients who are on insulin, it interferes with the assay. And she was found to have a C-peptide that was within the normal range. And so this signified that she was still making some insulin of her own. And as we said earlier, in patients who've got type 1 diabetes, making some insulin of your own is very unusual outside the honeymoon period, and she's now some 6 years down the diagnosis. So we went on to do genetic testing in this patient, which confirmed an HNF1 alpha mutation, missense mutation in exon 4, and confirmed a diagnosis of HNF1 alpha MODY. So we explained this to the patient, and we explained to her that one of the options would be that she could stop her insulin therapy and consider therapy with an oral sulfonylurea. And that's something that I mentioned is usually an optimal treatment for these patients. Now this is quite a difficult thing to explain to patients, because people who've been told that they have type 1 diabetes are also, it's reinforced in that every clinic visit they should never omit their insulin, that they're at grave risk of illness if they stop their insulin. So actually it took quite a long time to convince her that this was a safe option. And because these patients are exquisitely sensitive to sulfonylureas, we started at a relatively low dose of glycoside, so just half a tablet a day. And because she was quite anxious, this was done with 24-hour support from one of our diabetes specialist nurses. So how did she do? Over the next few months, she lost almost 20 kilos of weight, returning back to her baseline at diagnosis, and her HbA1c dropped from 8.6 to 5.8%. So we were pleased because her glycemic control had improved. She was pleased because she was no longer taking insulin, and she was also managing just half a tablet a day. But importantly for her, she'd returned back to her normal weight. So looking back now at the family, this is in 2011. So you can see the probands at the bottom still maintaining good glycemic control with an HbA1c of 5.8, just on half a tablet of glycoside a day. We did the same thing with her brother, so he's just on glycoside half a tablet a day with maintaining good glycemic control. And her mum didn't have any changes to her medication. She'd had diabetes for quite a long time, but still maintaining good glycemic control. So I just want to draw out a few lessons to be learnt from this case. So I think it really emphasises the importance of taking a family tree, and I know that's something that we've repeated over the course of the day. And I think it really helps to draw a family tree so that you can crystallise in your mind what the features are of all the people that are involved in that family and what type of diabetes they have. And actually, if someone had taken a family tree for this patient, then she might have been offered MODY testing at a much earlier stage in her diagnosis, because she actually does fulfil criteria for MODY testing. One of the clues to MODY in this case were that there were different types of diabetes within the same family. So there were people within the family who had a label of type 1 and type 2, and that should always sort of make you question whether there could be a different unifying diagnosis, such as a monogenic form. The case reiterates what we heard from Maciek earlier, that HNF1 alpha MODY cases are misdiagnosed and can be misdiagnosed as type 1 diabetes, and that obviously has important implications for the patient involved, so they can end up on lifelong insulin therapy if that diagnosis is never revisited. And one of the ways to question the diagnosis of type 1 that you're wondering about is to consider measuring a C-peptide level. So that's obviously much cheaper than jumping into sequencing. And I think this case emphasises that these patients can be safely switched from insulin to low-dose sulfonylureas. They might need support during that transition, but from a medical point of view, it is safe. And just to finally, with this case, a diagnosis of HNF1 alpha MODY has important implications for the individual patient, and this was a letter that this patient wrote to the nurse that was involved in her care, And I'll just read it out for you to really emphasise how much of an impact an accurate diagnosis can make. So she's written, "Where do I start? Thank you so much for all that you've done for me. I can honestly say that you've turned my life around. No injections is a dream come true, a dream that you've made come true. I don't think I could ever find the words to thank you enough." So before I move on to the next case, has anyone got any comments or questions that you'd like to make about that case? No? Oh, God. No, it's just a break. So...